I just want to make it clear that, and many thanks to the organising committee, looking at Samir in particular for the title of this talk, which was suggested to me. I think it is actually a very interesting title, not so much because I think Brexit has got anything to do with antifungal treatment in Europe or the UK, but what I want to talk a little bit about, having heard some really impressive, thank you Nicole and Johan, talking about how you're making decisions on treatment. We are talking, this is the third of a section of talks about real-world implementation. And Johan, I know, as he says, I mean, I find it phenomenal that you can get a bronchoscopy done on a Sunday, to be honest with you. And actually, I think that Oxford is a very good centre, but I would not be able to get a bronchoscopy done on a Sunday in Oxford. And I suspect that I'm not very different from many people around the world, actually. So what I think Brexit shows us a little bit is how we make decisions. And I want to talk a little bit about really real-world decision-making. So this was the result of a referendum that we had in June 2016. And none of, I would anticipate, very few of us from the UK in this room were expecting this, wanted it. It came as a complete surprise to us. But this was how the decision was made. And there were millions and millions of people who voted in this referendum. And it's impossible to absolutely oversimplify how the decision was made. But the decision was made, and on the 29th of March next year, so about a year from now, we will leave the EU. And I think that a major reason, first of all, why the decision was made was that people who voted, they didn't actually, it wasn't a racist thing, it wasn't about not liking European people, it was something about the past. So a lot of the people who voted wanted to look back at a previous time where they had a probably idealistic idea of England, where there was a sense of community, where there was high employment rates, and a lot of there's little doubt that a large component of the Brexit vote was about this idyllic idea of England. And I think in decision making we have to be aware that we're all influenced a lot by the past, and that can be a good thing when we're looking at randomized trials. That's absolutely admirable. But there's also pressure on clinicians when they're with a patient who's very unwell. They will make decisions which have been reflected by their previous training. And a lot of protocols, a lot of expert guidelines are actually, they are based on the past. And for me, this was my past. In a way, I look back at it as a simpler time. This was, if you ask me, this is my idea of empirical therapy. But actually, it wasn't empirical therapy. There was no choice to be made. That was all you could do in those times. So as now, we started off with antibiotics. After 48 hours, we now wouldn't necessarily change to vancomycin, but we're not talking about that today. And the nurses checked the temperature. And then after 3 days, you made it on to amphotericin. And actually, when I started, that was all we could do. So it was very simple. And people thought you were quite clever as a haematologist because you knew that that was what the protocol was to do. Now, the title, as well as including Brexit, also includes the word empirical. And I think that actually, I'm not sure I totally understand what empirical means, actually, because if you look at a definition of empirical, it means it's based on, concerned with, or verifiable by observation or experience, rather than theory or pure logic. And of course, if we're going to do that, it's essential that there's a process of audit that's going on. So the two speakers earlier on have given, they are empirical studies as well, in a preemptive way, if you understand what I mean. But you've completed that loop, that you've got strong data, you are observing and you're analysing what you're doing. And I think over my career with antifungal treatment, most of what I've done has been empirical, but following other people's pathways. And we've not actually been monitoring properly what we're doing. Now, we are trying to change that now in Oxford, but this is a really important thing. And I think that of the people in the UK, I would particularly Samir and the work he's done in trying to actually look and observe what you're doing is very, very important. So that was empirical in the 1990s. And the other thing I want to say, although protocols are really, really important and randomized trials are really, really important, I do think that in modern medicine now, the patient has to be at the absolute heart of the decision-making process. And it's individual patients are all different from each other. They're all having different treatment, they're different ages, they've got different renal function, they've got different liver function. And it is now becoming very, very difficult to really protocolize. And I think that when Johan put up his slide of the different, sometimes you end up with very, very big algorithms. And then when you're looking at an audience at a complicated algorithm, it's very difficult. But actually, that probably is the correct process to do, to go through this network approach with the patient at the heart of it. And everyone has got to be thinking about the patient at the heart, from radiology, from diagnostics, to infectious disease doctors, to nurses. And so what we do is we have a patient, we diagnose, we assess, we involve the patient in the treatment decisions. That may not be, that's certainly the case with chemotherapy, and it may not be the case with antifungal treatment necessarily, and then we treat them. And we want to get away from this simple thing that we used to do. And so the first two talks have been talking a lot about avoiding prophylaxis. And prophylaxis is treatment given or action taken to prevent disease. And of course, I actually think prophylaxis is probably, it is preventative treatment. We are treating the patient when we use prophylaxis. And in Oxford, we do use prophylaxis in selected patients. So I'm going to move on now and talk about the risk factors and evaluating the role of prophylactic treatment before we come into more what the first two talks about, how we can use diagnosis. Now, I'm going to start talking about a case, and this is something else that a lot of people fondly look back on in the past in the UK, the British Empire. And there was, I don't know where the pointer is, but those of you good with geography can see the Ascension Island there. And there was, a couple of years ago, a patient in the Ascension Island with the following blood count. So he was anemic, he had a very high white count. And amazingly, Oxford, which is a little bit further north of that, we are the haematology centre for the Ascension Island because there's a plane that goes from there to an army base near us. So if you're ill, you get flown to Oxford. So we were told this patient blood count, and he was flown over to see us. And he was breathless, not surprisingly, and he had AML. And we decided to give him chemotherapy with daunorubicin and cytarabine. So I'm only going to talk about one specific patient, but this, I think, is the way we need to think about every single individual patient as to how they are. Now, I think we'd all agree that this patient is high risk, and how do we know that? Because when you give DAR chemotherapy, you're neutropenic for 30 days from starting the chemotherapy, so it's a long time. And bear in mind, they're often immunocompromised for a long time before that. So probably AML induction is just about the worst thing you can do in terms of immunosuppressing a patient, but it's essential for them. And we're very grateful. I think that the European guidelines, the ESOL guidelines, it's a very useful process in looking at risk and treatment, and certainly if you look at the risk factors that might be recommended for someone to have prophylaxis if you're going to use it, then a history of neutropenia is up there. Allogeneic transplantation and steroids are also, and then there's other things like T-cell immunosuppression and inherited severe immunodeficiency, which are also important factors. So this patient is at high risk of invasive fungal disease. Now, we may all differ from this, from using no prophylaxis, if we're going to use no prophylaxis, to using prophylaxis. But we are very swayed by the Cornelli data, which did the randomization between just fluconazole or Erythra against posaconazole. And basically, for this patient group, there was a significant reduction in invasive fungal disease if you use posaconazole prophylaxis, and also there appeared to be improved survival. So based on that, we made the decision to put this patient onto posaconazole prophylaxis. And I think that it would probably be the, on terms of the evidence basis, that when we saw the patient, that would be the outstanding choice for prophylaxis. This was a couple of years ago. Now, not every patient is the same, and when you're making a decision on empirical use of prophylaxis, if you like, then not all patients use them. So at the moment, the standard guidelines for myeloma is that they're not for routine prophylaxis, although the treatment of myeloma is now becoming so immunosuppressive and the survival of myeloma patients is becoming so long that that's certainly something that we need to keep our eye on. In MDS, then prophylaxis is only really standardly used if they're on AML chemotherapy. I'd probably include azacitidine with that or having a transplant. For CML, the treatments are not very immunosuppressive with TKI, so it's only if you get into blast crisis, which is unusual now. ALL is certainly high risk, but it's not clear what to do because of the use of azoles on vincristine. CLL, again, not for routine prophylaxis, but we have to recognise that patients can be at high risk. And lymphoma patients, not for routine prophylaxis. So you've got quite a diversity of hematological diagnoses there. And sometimes they need prophylaxis, sometimes they don't. And then what prophylaxis are you going to use? Well, there's probably, I won't talk you through this table here, but there's a variety of evidence, most striking for posaconazole if you're on steroids for graft versus host disease following an allograft. So what we do at the moment is that we have our own pragmatic list in Oxford of patients that we feel are high risk, low risk, or very low risk. And these are patients that this is what we would decide for use for prophylaxis. So basically, if you're high risk, we would use posaconazole. I'll come to a possible change in that now. And then if we're low risk, we just use a very low dose of fluconazole simply for oral candida and nothing else than that. And then if you're very low risk, we don't use anything. But last year, we made the decision with voriconazole becoming generic that actually we found it very difficult to justify spending the money on posaconazole, although it's still commissioned, and we switched to using voriconazole, and we will only use posaconazole in selected patients, especially if they're having side effects with vori, then obviously there's no problem with moving there. So that's what we're doing at the moment in terms of our prophylaxis. Anyway, this patient was treated a couple of years ago before we used voriconazole, and so he was on posaconazole prophylaxis. After a couple of days, he became hypertensive and tachycardic. He'd only been in for a couple of days, and he'd had a long flight, and he had a high white count. So, fortunately, the registrar requested a CT pulmonary angiogram, and the bottom line was this CT scan did not show invasive fungal disease, it showed PEs. And so he was given a bit of appropriate anticoagulation. However, time moved on, and by this point, he'd already started on antibiotics, and we did use vancomycin for various reasons, but he had a new fever. So this was 12 days. And this is a very, very common problem. This is going to be happening around Europe, the UK this weekend. You get someone who's on antibiotics, of course, and do you change treatment? And I think I just want to make the point that it is attractive to change. And this was something else, I think, about the Brexit. So there was looking at the past, but also change people think is desirable. And your clinical staff feel better if they change something. They'd stop worrying about it. So it's much harder to not change a treatment. If you're a registrar on call at a weekend, it's much harder to not change treatment and everyone rolls in on Monday morning and say, why didn't you do this, than to switch them. And once they switch treatment. So there is a big pressure to switch the treatment. Anyway, this wasn't on a Saturday, which maybe would make a difference to the decision-making. So the patient went off and has had a CT scan, which is certainly our desire. And I think it's also important that we get the CT. Part of I'm wary of weekend CT scans because of who's going to report it, and it may be reported by a radiology registrar or non-specialist consultant. And there was a right upper lobe nodule with a peripheral halo in keeping with infection. And fungal etiology was felt to be the most likely cause, and this was from a specialist chest radiologist who I've been working with for many years. So what do we do? And certainly swayed by people who are in this room, we are now trying to move away from umbilical treatment when we possibly can do, and rather than switching treatment, the patient went and had a bronchoscopy. Now, can I just say that having a bronchoscopy is not that much fun if you're a patient. I think we'd all recognise that. Now, most patients I talk to will have very few complaints about it. They seem to be well sedated, but they will be frightened beforehand. You are putting the patient through an invasive procedure. And actually, of patients who've had bronchoscopies over the last 3 years, this is the only one I can remember who had any side effects. But he came back, and possibly it was because he had a PE and he was having a bronchoscopy, so we've just got to think about that. But he came back, and you can see from the saturations there that actually he needed to go on high-flow oxygen, and we had high TU at the end of the bed, and this was all very alarming. But actually, he gradually, over a few hours, things settled down, and he was absolutely fine. And then we got the test results back. And this does take a few days for us, because this was a Friday bronchoscopy, by the way. We do a send away for our galactomannan, so they certainly wouldn't have gone till early next week. So we're waiting for these results. But anyway, this is a very straightforward story, which is probably why I'm telling it. The galactomannan was interpreted as being negative. The fungal cultures were negative. They did actually see E. coli. We did a switch to meropenem. And we did not change the antifungal drug. So this is the sort of pathway that your patients are going to be going through all the time, and you've got to think about the different steps when the decisions are being made. So looking back, and looking back now is becoming much, much easier for us because we use electronic patient record. So I've never had any appetite to inflict on someone going through temperature charts from pooled notes. But now, for the last 3 years, every pulse, every neutrophil count, every blood pressure, everything is electronically collected. So it's now becoming very much easier for us to actually do this. We still had to define patients, 115 patients who were treated over over an 18-month period, who were defined as being high risk. And then we collected additional laboratory data as well. And we did also try to get the post-mortem reports, because if we don't know the cause of death from diagnostic purposes, we always ask for a limited medical interest post-mortem on our patients. So bear in mind that we're giving these patients most of them receive prophylaxis. I'll talk about that. What we found that the treatment change occurred for actual treatment rather than prophylaxis in 32% of patients, so 37 of them. And what was this based on? So we're pretty good at doing CT scan, although it's not 100% of patients who actually had that change. When we look, it's only 90%, but we're quite good at that. And of these patients, then nothing like what we've been hearing earlier on. It was a small number, it's only 15, it's 40% of patients who had a lavage. And what we found was that only one of these lavage results actually we defined as showing that there was aspergillus on the basis of the galactomannan, and there was a positive aspergillus cytology. So we are trying to get better at doing lavage, but at the moment, in Oxford anyway, based on this audit, that it's less than half of patients who've got abnormal CT scans who are passing through to have bronchoscopy. When we looked post-mortem, then one patient had fungal brain disease post-mortem. He'd also had a candida in the chest. Two patients actually, this was higher than we previously had. Two patients had candida detected in blood cultures. So we come out with 3 possible IFIs, 3 deaths, 2 probable IFIs, probable IFIs in 2 deaths, and proven in 1 death. Both patients with the probable had received mold-active primary prophylaxis with posaconazole. We use quite a bit of prophylaxis, so the median duration of prophylaxis was 38 days. I should probably call prophylaxis preventative treatment, and then the median duration of, if you like, active treatment, if I can call it that, was 12 days. And we found that 86% of all antifungal prophylaxis and treatment adhered to our local guidelines, which probably isn't bad, but it's still not, you know, it should be 100% because we've got a limited pool of people who are looking after our patients. So my conclusions from this is that we have using a mainly prophylactic-based algorithm, we're still having to treat a significant number of people, and obviously, probably, if you take these figures literally, more than you're treating by not using prophylaxis. 40% of the patients had bronchoscopy, but one of those, as we said, he was quite unwell when he came back. Should we have not done bronchoscopy because he'd had a PE diagnosed a little while before? I'm just not sure. Not included in what I've shown you, but I think we're much better now at educating our chest physicians to send them off for the right tests. And again, an advantage of EPR is that we've now got an automatic care set where they request the right tests. And 6 patients of the whole group died with possible, probable, or proven in IFI, which is, you know, probably fits in with the general rates of what we see. So just sort of moving towards the end of what I wanted to say now, in terms of the decisions, this is quite an interesting study. It was a survey from the States of lung physicians, oncologists, hemato-oncologists, and infectious disease physicians. And it was asking them about the care of stem cell transplant patients. And the questions they were asked is, physicians who leave this to the pulmonologist to decide, so the oncologists, 56% of them do, 25% of the ID physicians, obviously the pulmonologists all think it's very good. How often does the bronchoscopy yield a positive result? And so they say never or rarely. 37% of the lung doctors think that. The oncologists and the ID doctors think about 14%, 10% across them. And how often does the bronchoscopy in a stem cell transplant patient lead to a change in management? And the pulmonologists think that never or rarely in about half of the cases, and then oncologists and ID doctors, 27% and 13%. Those are the questions. They're slightly loaded questions because actually we're talking about change, but if you're not changing, if it makes you not change, then I would see that as being a very positive thing. So for you, it's making you not change when you're not giving preemptive treatment. So I think that not changing is a very good reason for doing a bronchoscopy, and nothing to be ashamed about, which is possibly not quite how the paper's written. So what next? What for the future? And I think as we all go forward on our units, and nationally, if we've got national protocols, what we have to do is we have to use the correct evidence. And those of you outside the UK may not know that this is a very famous bus that was for the Brexit campaigners used, and they drove it around saying, we send the EU £350 million a week, let's fund our NHS instead. So they used this very spurious, in fact, false news data that there was huge amounts of money that could now go into the NHS if we left the EU. So we need to use the right data, the right evidence in deciding what we do. We also need to ask the right people. And this is the age of the people who were voting. And if you look at the life expectancy of these different groups, I don't know if you can see at the back, basically 18 of the 18 to 24-year-olds, then only a quarter of them wanted to leave and 3/4 wanted to remain. And the life expectancy of this group is 69 years. Whereas of the 65-year-olds, it all shifts. And so I don't want to talk about democracy, but if all of the younger people who are going to be most affected had voted, there's no doubt that we would have remained in the EU. And so in your decision making, you do have to think about asking the right people. And I'm not sure that I'm the right person to ask. I may be a better person to ask now than I was 10 years ago because I'm more interested in this, but I'm a hemato-oncologist and I'm worried about leukemia. I'm worried about, is someone going to be dying of their bone marrow transplant? These are the issues. And this is an increasingly complicated area. So I absolutely agree with what Johan was saying, that you need to have custodians of what you do with the antifungal management who make the decisions together. And then finally, there needs to be some harmonisation, because with the Brexit vote, the blue is Remain. You can see Scotland remained, London, Oxford, we were all blue, Remain, but it was very, very geographical, the split of the vote. And if you had a map of Europe at the moment, I think that you would see similar huge differences, and certainly in the EU, in the UK at the moment, there's huge differences. And I think certainly personally, and I know Samir agrees, Tony would agree with this, that we would like in the UK, at least that we could start making a contribution by doing things a little bit more similarly as a country to contribute to the European debate. So our conclusions are that patients with hematological malignancy must be assessed for the risk of fungal infection. I would say prophylactic therapy can then be selected, but I quite accept that if you can run a unit and a team where you've got excellent diagnostics, then you maybe don't need to use prophylaxis. I think further studies are necessary to clarify the optimal prophylaxis for the changes with azole resistance and the more immunosuppressive treatment we're going to use in hematological malignancy. And we must have future collaborative studies to guide us in diagnostic guided therapy change. And finally, I think, as Tony said at the beginning, that although we're leaving the EU, it's absolutely not something that we wanted. And fortunately, unless some massive earthquake happens, as far as I know, we're definitely not leaving Europe. And we're very keen on continuing to hear really the wisdom of what you're doing in Europe at the moment. Thank you for listening.